So without further ado, lymphoma management in North Carolina, updates for 2023 and this is June 28th, 2023. Natalie Grover, MD, is an assistant professor in the Division of Hematology Oncology. Her primary clinical interest is management of lymphoma. Her research interests include novel treatment strategies in lymphoma, particularly immunotherapy, and she is currently involved in clinical trials of chimeric antigen receptor T-cell CAR T therapy for patients with lymphoma. And those top facts: assistant professor in the Division of Hematology Oncology, primary interest in management of lymphoma. Interests include novel treatment strategies in lymphoma, particularly immunotherapy, and then involved with those clinical trials of chimeric antigen receptor T-cell CAR T therapy for patients with lymphoma. And here's a sample poll everywhere slide. This is just like what you'll see, and then you'll be able to respond to it in a minute. And I will put up the disclaimers so that you've seen those. So Dr. Grover, what's one other thing that we should know about you outside of your professional bio?
So I enjoy traveling a lot. I used to travel more pre-kids. Now most of our traveling is more local, but we love going to the beach and the mountains and doing both this summer. Spent a lot of time in Blowing Rock Boone, hiking, because of my son's train enthusiasm, going to Tweetsie Railroad. So we love spending time there.
Oh, that's great. That sounds really nice. We just got back from Grayson Highlands last weekend up in the Southern Virginia border, and I love the mountains here. That's great. Thank you so much, and thank you for being here. Let's take a look at, and I actually need to pass these answers through, so bear with me for a moment here. But the question is, what one word comes to mind when you think about lymphoma? And so we've got several responses: nodes, steroids, blood, transplant, lymph nodes. Let me go ahead and load some others. Bulky, rituximab. Cancer. Thank you so much to all of you who are responding. Let's take just another 20 seconds or so. We still do have more coming in. Anything that you would say about these responses?
Yeah, they're all good. I guess. Yeah, they're all good. Lots of different things.
Great. Well, thanks. And that's always a nice way. We try to do sort of a softball at the beginning just to get people comfortable with the poll everywhere. So be ready for our audience for plenty more questions coming up. Dr. Grover, I'll turn it over to you.
Oh, thank you. Yeah, thank you so much for having me. I was given the task of talking about lymphoma management in North Carolina, updates for 2023. And there's been a lot of activity in lymphoma and lymphoma research and in management over the past year or so. So I'm excited to share some of that with you all. So to start off, I'm going to start off with a case. A 28-year-old female presents with enlarged neck nodes. She has an excisional biopsy consistent with classical Hodgkin lymphoma, and she has a PET scan which shows lymphadenopathy along in her neck, chest, mediastinal area, retroperitoneum, and uptake is significantly greater than that of the liver, as well as some pulmonary nodules that are suspicious for lymphoma involvement. And the question is, how would you treat this patient? And a lot of this is changing, so there's not necessarily one right answer, but 6 cycles of ABVD, 2 cycles of ABVD followed by PET scan for response adapted therapy, escalated Bayacop for 6 cycles, brentuximab vedotin of ABD for 6 cycles, or nivolumab ABD for 6 cycles. I don't know how much time to. This looks like people are some responses are still. Looks like some responses are still coming in.
Yeah. I think we're just about there. So I maybe 5 more seconds. How are they doing?
Yeah, and there's not really a right or wrong answers per se. But I'll kind of talk through and talk a little bit about some of the changes coming up right now too. And a lot of this has changed. So the standard of care for the longest time for Hodgkin lymphoma had been ABVD, or Adriamycin, bleomycin, vinblastine, dacarbazine for many, many years. And since about 2016 or so, we had been using this response adapted or PET guided approach frequently, where basically we start patients with 2 cycles of ABVD, and then we would de-escalate, or less frequently escalate therapy based on their interim PET scan. So if their interim PET scan showed a complete response, which based on the PET scan and the brightness was a Deauville score of 1 through 3, we would drop bleomycin at that point. And then if the interim PET scan showed a response, but not a complete response, where there was still disease that was avid or bright on the PET scan, we would escalate patients to more aggressive therapy. And so this is the approach we've been using a lot and have been using for many years. And the advantage is that most patients respond. So it's great because then you're able to drop the bleomycin after 2 cycles to reduce the risk of pulmonary toxicity. But there are disadvantages to this approach as well. It relies on expertise and assessment of the nuclear medicine team. And at UNC, our nuclear medicine team is very experienced, but in some places they're not as used to giving a Deauville score, so they may not be as comfortable with that. And so once in a while, we get a read that has been read somewhere else where our radiologists have a different opinion. So there's some controversy, can be some controversy with that and make it more complicated in that setting, since you're making decisions based on that score. The other drawback is that we hate escalating to VACOP. So in the rare case where patients do have residual disease, that regimen does have a lot more toxicity, including risk of an infection, secondary malignancies, infertility. So a lot of times, when I do use the response adapted approach, if someone still does have residual disease, we oftentimes would just continue ABVD in this setting because we really, because even though we know this population is at risk for worse outcomes. So brentuximab, so most of you know, over the same time period, there have been 2 novel agents that have become really active in the treatment for Hodgkin lymphoma and frequently incorporated in the care of these patients. Brentuximab vedotin is an anti-CD30 antibody drug conjugate. And then also we've had checkpoint or PD-1 inhibitors, nivolumab and pembrolizumab, which are very active, but also very active in treatment of Hodgkin lymphoma. And so we've been using these a lot in relapse refractory Hodgkin lymphoma and also moving them to earlier and earlier lines of therapy. So one question was, can we incorporate these new therapies in frontline therapy and improve patient outcomes? So there was a study several years ago, and this was presented at the plenary session at ASH in 2017. And this incorporated brentuximab vedotin as part of frontline therapy in Hodgkin lymphoma. And so this was published in late 2017. This was a phase 3 randomized trial. It treated over 1,000 patients with advanced stage, so stage 3 or 4 Hodgkin lymphoma. The median age was 36, but patients were up into their low 80s on this trial. And it randomized patients to either 6 cycles of ABVD or 6 cycles of brentuximab of AVD. So you're not giving bleomycin in that trial for the patients in the brentuximab arm. And so this trial, the initial report, as I said, was presented to ASH plenary in 2017. It showed an improvement in 2-year progression-free survival with BVAVD compared to ABVD. And this was exciting. It was really exciting to see because there was something that beat out ABVD, which we had been using for many years. There still was some skepticism of this result, so we didn't start incorporating this regimen right away. There wasn't initially an overall survival benefit, and there, of course, were concerns around cost and access to brentuximab and availability. And then some people were, saying we use a lot of brentuximab in salvage, so we want to use our best drugs to start with, or do we want to save them for later as well. And the other concern is that brentuximab ABD plus ABD does have higher rates of toxicity. There were higher rates of neutropenic fever in the BV-ABD arm. So the trial actually midway added the requirement of growth factor to the BV-ABD arm. And there also is more neuropathy because you're using two agents, brentuximab vedotin and vinblastine, that both cause neuropathy. So again, with just the PFS benefit, people were starting to use it, but not everybody was using it because of some of these concerns around toxicity as well. And then last year, there was a change, and the New England Journal of Medicine, there was a publication, finally the follow-up period at the 6-year follow-up, there finally was an overall survival benefit of brentuximab vedotin plus ABD over ABVD. And the 6-year overall survival of 93.9% for the brentuximab arm compared to 89.4% for the ABVD arm. And I think this overall survival benefit convinced more of us to incorporate this as our standard of care for advanced stage Hodgkin lymphoma. And this is what I've been using for patients. I still don't think it's necessarily wrong to use response-adapted therapy or ABVD for some patients, especially those with a history of neuropathy. And this is BV-ABD is probably overall a more toxic regimen, but the overall survival benefit really skewed me in towards using this more and more in my patients. But wait, there's more. There's exciting news. As I was preparing this presentation, exciting news came out of ASCO this year. There had been a randomized trial that UNC also participated in, as well as other local sites, which randomized Nivo brentuximab ABD, which is it's now more or less considered a standard of care for Hodgkin lymphoma advanced stage, to nivolumab, randomized patients to brentuximab ABD or nivolumab ABD, using checkpoint inhibitors and frontline therapy. And this was just read out this year at ASCO and Lugano this summer. And this was organized by the cooperative groups. SQUAD was a main cooperative group, and Dr. Herrera there, and UNC also participated too. So the early readout is Nivo ABD improved progression-free survivor compared to BV-ABD. And actually, the study was designed as a superiority trial as well. So this was the hypothesis. So at 1 year, and so again, caveat is the follow-up is really short, but at 1 year, the 1-year progression-free survival for nivolumab ABD was 94% versus 86% for brentuximab ABD. And again, the data is not very mature, and the follow-up is just at 1 year, but this is still very exciting. I think the other thing that makes me excited about this is that overall, nivolumab ABD is a less toxic regimen compared to brentuximab ABD. And I mean, I think many of us giving BV-ABD have felt that it is more toxic and harder to give. There's more neuropathy, and some patients are getting more diarrhea. And overall, just having more side effects. Nivolumab ABD has less peripheral neuropathy since you're not giving brentuximab. There are similar rates of febrile neutropenia, even though only about half of patients in the nivolumab arm got growth factor compared to most patients in the brentuximab arm, suggesting that maybe you don't have to give growth factor to these patients that are getting nivolumab ABD. And young patients, a lot of our Hodgkin patients are young, and in young patients, growth factor can cause a lot of bone pain and discomfort, which also interferes with their quality of life. And also, of course, cost. So not having to give growth factor is also an advantage. One thing we think about for checkpoint inhibitors is immune-related adverse events. And in the nivolumab ABD arm, the most common was thyroid dysfunction in about 10% of patients in the nivolumab ABD arm. So that's something to think about. But there were not increased infections in the Nivo ABD arm. And otherwise, pretty much with all other toxicities were either similar or worse with the BV-ABD arm. So the question is, how do we treat advanced stage Hodgkin lymphoma in 2023? What does all this mean? I'd like to start off the caveat that follow-up is still short. I do anticipate that if trends continue, and I do expect them to, as there have been some single-arm studies that have shown durable benefits with checkpoint inhibitors and frontline for Hodgkin lymphoma. So I think soon nivolumab ABD will become our standard of care for frontline Hodgkin lymphoma, given its improvement in progression-free survival and favorable toxicity profile. And then the other exciting aspect of the study is that it included pediatric patients too. So for the longest time, we have been using different regimens for adult patients and pediatric patients. So I think it's exciting to have something that more standardized. For now, I'm treating patients mostly with brentuximab AVD due to insurance barriers. Follow-up is still short. Nivolumab AVD is not in the NCCN guidelines yet. It's not been FDA approved yet for frontline. So getting insurance authorization will probably not happen yet. So I think right now I'm mostly still using BV-AVD, but I think very soon, maybe even within the next year, we may start using nivolumab AVD more regularly as the data matures and guidelines change. So what's next? The next clinical trial in frontline advanced stage Hodgkin lymphoma will likely work to incorporate both brentuximab vedotin and nivolumab in frontline together, and also potentially use imaging techniques and biomarkers such as circulating tumor DNA to identify patients who need to either be escalated or de-escalated for therapy. So likely in the future, we may see us using both brentuximab and nivolumab potentially in frontline for Hodgkin lymphoma together, and potentially limiting some of the chemotherapy, potentially maybe taking out vinblastine. There's also interest in the incorporating novel agents for patients with early stage Hodgkin lymphoma. All of this that I've been talking about is more advanced stage Hodgkin lymphoma. And so in early stage, we're still mostly using traditional cytotoxic chemotherapy and not incorporating novel agents as much. So there is an early stage cooperative group trial organized through COG, the Children's Oncology Group, that again will be including both adult and pediatric patients. So that would be randomizing patients to initially starting off with standard chemotherapy, but then they get a PET scan in the middle, and then randomizing patients to either getting brentuximab and nivolumab versus just standard of care after the interim PET scan. So I think we'll soon be incorporating chemotherapy, novel agents in early stage Hodgkin lymphoma as well. So back to our case. So this is the same case again of this 28-year-old female with what looks likely like stage 4 Hodgkin lymphoma with disease above and below the diaphragm, as well as some pulmonary involvement as well. So I'm asking again, how would you treat this patient? Yeah, so it looks like before people were thinking more kind of the PET adapted approach, and now people are thinking maybe more incorporating some of these novel agents, which is right. And again, right now, ideally I would like to treat this patients with nivolumab AVD, but probably at this point, given kind of insurance barrier and cost barriers, probably would do brentuximab AVD unless she had a history of significant neuropathy already or some concerns around that. And then, but in the future, I think soon we'll be using checkpoint inhibitors frontline. Looks good. So moving on, we have a 65-year-old female who presented with right upper quadrant pain and weight loss, and was found to have diffuse mesenteric, retroperitoneal, mediastinal, and hilar lymphadenopathy. Biopsies consistent with diffuse large B-cell lymphoma, and FISH is negative for MYC rearrangement. Labs are significant for an elevated LDH above the upper limit of normal. And the question is, how would you treat this patient? R-CHOP, dose-adjusted R-EPOC, or polatuzumab R-CHP. I'll give people a little bit of time to respond. And again, there's not really necessarily a right answer here. see people saying mostly R-CHOP. Oh, sorry. Mostly R-CHOP, but some people thinking about EPOC or polatuzumab as well. So I'll talk a little bit. I'll talk a little bit about polatuzumab, and that's a relatively new drug. So polatuzumab vedotin is an anti-CD79B antibody drug conjugate. It targets malignant cells in B-cell lymphoma and delivers MMAE, which is a microtubule disruptor leading to cell death to the cells. So it's similar to brentuximab vedotin, but it has a different target. Brentuximab has CD30 as a target, while polatuzumab has anti-CD79B. So some of the same toxicity concerns around peripheral neuropathy as brentuximab as well. So it's been FDA approved since 2019 in combination with bendamustine and rituximab in the treatment of relapsed refractory large B-cell lymphoma. So with that, there was interest in seeing if that could be incorporated in the frontline treatment for diffuse large B-cell lymphoma. So there was a randomized trial, the Polarix trial, which compared polatuzumab with R-CHP. So it's R-CHOP, but vincristine was removed because of concern around neuropathy, versus standard R-CHOP, which has been a standard for large B-cell lymphoma for decades. So this was a phase 3 double-blind placebo-controlled trial, and this was open at UNC. This included patients who had intermediate or high-risk disease by IPI score, so an IPI of 2 or higher. So these were slightly, higher risk disease. They randomized 879 patients, and in this trial, this was read out at ASCO. I think at ASH, the plenary in 2021, polatuzumab R-CHP did have an improvement over R-CHOP for progression-free survival. So the 2-year PFS for polatuzumab with R-CHP was 76.7% compared to 70.2% for R-CHOP. So depending on who you were, you had different reactions to this trial. Some people saw this and said, this is the first, R-CHOP has been dethroned. There's been so many different regimens, including dose-adjusted R-EPOC, that have been compared to R-CHOP, and none of them have, in randomized trials, and none of them have been able to beat out R-CHOP. And so finally, there's something that's showing a benefit over R-CHOP. Other people kind of looked at this and said, what's the big deal? This is such a small, tiny benefit. We're not seeing an overall survival benefit. This is an expensive drug. Why should we change what we're doing? So there were different reactions, different camps of different reactions. So again, there was no difference in overall survival. Probably because of, and this is maybe because we have better therapies like CAR T cells earlier for patients, and also it's still short follow-up, right? It took 6 years for the Echelon, the Hodgkin lymphoma trial for brentuximab to show an overall survival benefit over ABVD. The main difference here is there was a similar toxicity profile as opposed to with brentuximab ABD compared to ABVD, where there was a lot more neuropathy and more infection. There was the toxicity profile between Pola R-CHP, and I don't have it here, but an R-CHOP was very similar. So this led to the FDA approval. So just a couple months ago, in April of 2023, polatuzumab was FDA approved in frontline in combination with R-CHP for therapy for diffuse large B-cell lymphoma, just for patients who have an IPI of 2 or higher in advanced stage large B-cell lymphoma. So so how should we use it? So should we use this regimen is the question. I think there has overall been mixed uptake in the lymphoma community. I think more and more people are using this regimen. There is an improved progression-free survival. And we know that patients, once they have relapsed refractory large B-cell lymphoma, it does become harder and harder to treat them as we go further and further along in therapy. Again, and there's also similar toxicity profile. So you're not generally really adding much more toxicity with this combination. However, there is higher cost. And this does require growth factor. They did include growth factor support for these patients. So that also adds additional cost. And there's also questions about maybe there's certain subgroups of patients that may benefit more from polatuzumab than other. There's some questions about the activated B-cell subtype in diffuse large B-cell lymphoma. although we have to be really cautious in interpreting these subgroup analyses. So personally, I have incorporated this regimen as my standard of care for frontline advanced stage large B-cell lymphoma, since my rationale was generally if it has better outcomes, even if not a huge difference, and it doesn't seem to have more toxicity. To me, it seems overall worth it. But I do think it's still appropriate to use R-CHOP. Some trials and some people are still using R-CHOP generally. So I think this isn't enough for me to say that everyone needs to get this POLA RCHP, but I am starting to incorporate it. So the past few patients with newly diagnosed advanced stage large B-cell lymphoma, since the FDA approval, I have incorporated POLA in frontline. So here is the case again of this 65-year-old female who has at least stage 3 large B-cell lymphoma. And based on her stage, she gets a point, and her age and her elevated LDH, she probably has at least an IPI of 3. So it's in that higher risk category that it was included in the Polarix trial. So the question is, how would you treat this patient? And I think before I didn't go over it, but in general, she didn't have a MICRE ranges. She's not double hit, so I generally wouldn't do EPOC. And there was a trial comparing R-CHOP and EPOC that showed R-CHOP no difference in outcomes, but R-CHOP of course had less toxicity. I'm not going to go over into double hit during this presentation, but there are still some scenarios where I may consider EPOC, but we're using it overall using it less and less, and mostly using, and the group here is pretty split between R-CHOP and POLA RCHP, which I think is pretty much where the lymphoma community is right now too. Pretty split between the two. So for this patient, we treated with POLA RCHP for 6 cycles. She initially gets into a complete remission, but 4 months after completing therapy, she presents with worsening abdominal pain and nausea and is found to have diffuse FDG avid lymphadenopathy consistent with relapse disease. And so the question is, how would you treat this patient? Salvage chemotherapy followed by an autologous stem cell transplant, salvage therapy followed by allogeneic stem cell transplant, CAR T cell therapy, chemotherapy alone, or hospice. And it looks like the group is mixed, maybe more people thinking about transplant in this setting. Give you a few more seconds. So it looks like pretty split, mostly between transplant and CAR T. And I remember when people were talking about what they thought about lymphoma at the beginning of the words, there were some people who said transplant and some that said CAR T. So the prior standard of care for the longest time for large B-cell lymphoma has been high-dose chemotherapy followed by an autologous stem cell transplant in responding patients, and this is based on the PARMA trial. So in the PARMA trial, patients who had relapsed or refractory large B-cell lymphoma all got 2 cycles of combination chemotherapy with DHAP, which is a standard salvage regimen for large B-cell lymphoma. And then patients who were in a partial or complete response, so the patients who were showing sensitivity to chemotherapy, were randomized to either getting a stem cell transplant, an autologous stem cell transplant, versus 4 more cycles of chemotherapy. So in this clinical trial, the 5-year event-free survival was 46% in the transplant arm compared to 12% in the chemotherapy arm. And this trial was published in 1995, so almost 30 years ago. And this established transplant as a standard of care for patients with large B-cell lymphoma who got salvage chemotherapy and were responding to it. So there, of course, are many limitations to stem cell transplant in large B-cell lymphoma. as those of you that do transplant may know. So diffuse large B-cell lymphoma is a disease of the elderly. So many patients may not be, with large B-cell lymphoma, may not be transplant eligible due to either their age or their comorbidities. Another issue is that many patients end up not being transplant eligible because they're not responding to salvage therapy. And this is probably about half of patients with relapse refractory large B-cell lymphoma. So they get their salvage chemotherapy, but they're not, they are then refractory to chemotherapy, so that those patients are not candidates for an autologous stem cell transplant. And those patients would not have gone to transplant in the PARMA trial either. So a lot of patients that we think, even in the patients that we're thinking about transplant, many of them don't get there because of their disease not being sensitive enough to therapy. And then there's, of course, a question about kind of the rationale behind transplant, which is this a large part of autologous stem cell transplant is the high dose chemotherapy that patients are getting. And so if patient is already refractory to chemotherapy, is more chemotherapy, like that high dose conditioning regimen, really going to be the right option for these patients? Is more, if they're refractory to chemo, is more chemo really the right thing to do? So CAR T cells have, past several years have entered the space and been used a lot more in large B-cell lymphoma. And CAR T cells stands for chimeric antigen receptor T cells. Basically, a patient's T cells are altered so that they can more specifically recognize and attack cancer cells. So in this process, the patient's T cells are extracted and then genetically engineered to target the tumor or a marker or antigen on the patient's cancer cells, and expanded and then infused back into the patient's body, where they can continue to multiply, recognize, and destroy cancer cells. So in this setting, in large B-cell lymphoma, the target is CD19, which is a target seen in B cells, a target which is present on majority of B cells and also in malignant B cells in lymphoma. So, and that has been used, and that CD19 directed CAR T cells are the T cells we generally use for large B cell lymphoma. And so there are 3 CAR T cell products currently approved for patients with relapse refractory large B cell lymphoma. And those are Axicell, and I'm using the shortened names because they're quite a tongueful: Axicaptogen, Solucil, Lysocell, or Tezacell. The complete response rate for these products are around 40 to 60% in large B-cell lymphoma, and many patients in complete response do seem to show more durable responses. So the logical question with the success of CAR T cells is whether these treatments can be moved to earlier lines of therapy and maybe potentially even replace autologous stem cell transplants. So there were 3 randomized trials comparing second-line CAR T cells to autologous stem cell transplant. These trials included patients who had large B-cell lymphoma or high-grade B-cell lymphoma who were primary refractory, and that means that they didn't respond to initial therapy or progressed with initial therapy, or they're patients who relapsed within 12 months of finishing their initial therapy. So patients also, of course, had to be a candidate in this trial because they're randomizing patients to transplant or CAR T. They also had to be candidates for transplants. These trials were intention to treat. So basically, a patient would get randomized to either get CAR T cells or get standard of care with the plan of going to transplant if their disease was chemosensitive. So the most mature trial of all of these was the ZUMA-7 trial, which looked at Axicell for CD19-directed CAR T cell therapy. And then this was presented in 2021, I think, in the ASH plenary, and they presented and showed an improvement in progression-free survival in the CAR T arm over the standard of care arm for second-line treatment with Axicell. And so that led to the approval of Axicell for second-line treatment of large B-cell lymphoma. So this difference has held with longer follow-up, And you can see here that the median progression-free survival for axi-cel was 14.7 months compared to 3.7 months with standard of care. With the 4-year progression-free survival of 42% for axi-cel and 24% for standard of care. And again, remember, this isn't really randomizing people CAR T to, this isn't the standard of care arm isn't necessarily transplant, because again, not everyone made it to transplant because these are patients who got chemotherapy with the goal of getting to transplant. And then the big news, and this was presented this year at ASCO and also just published concurrently in the New England Journal of Medicine, is that there is an overall survival benefit for axi-cel, the CD19 CAR T cells, over standard of care, with the median overall survival for axi-cel not reached, and the 4-year overall survival for axi-cel at 55% versus 46% for standard of care. This is especially significant because, of course, the standard of care arm trial, they were allowed to cross over and get CAR T cells if they progressed or were not either post-transplant or couldn't get to transplant. So many patients in that arm still got CAR T cell therapy. And I think I have something about that in my next slide. So there were 2 other trials. So I was talking about the axi-cel or the Yescarta trial that showed the second-line CAR T cells, There were also 2 other trials for the other 2 products as well, comparing second-line CAR T cells to standard of care. One of them was the liso-cel trial, and that was the transform trial, and that showed similar results to the axi-cel trial, although the data hasn't matured enough, so the overall survival difference hasn't been reported. However, they did show a progression-free survival benefit for liso-cel over standard of care, and liso-cel was approved in 2022 for second-line therapy for large B-cell lymphoma as well. The other product is tisa-cel, and that did not show a difference between CAR T and standard of care. And there are some theories why this may be the case, both related to study design and possibly product attributes. But bottom line is that tisa-cel is not FDA approved for second-line therapy. But we have 2 products. We have 2 products that are axi-cel and liso-cel. And so the question is, should we change our management of patients with relapsed large B-cell lymphoma based on these results? So my general answer is yes. And I think that patients with primary refractory or early relapsing large B-cell lymphoma should definitely be referred to a CAR T-cell center as early as possible. There's significant benefits seen, even though there were high rates of crossover to CAR T in the standard of care arm, suggesting the benefit of referring these patients early and also treating patients with CAR T cells early. And so that the other thing to remember is that low number of patients in the standard of care arm received autologous stem cell transplant. And actually in the standard of care arm, more patients, the arm that was randomized to transplant or standard of care, more patients got CAR T cell therapy than transplant. And that really speaks to the fact that this patient population, these early relapsing large B-cell lymphoma patients, even if you're thinking about doing transplant, most of them can't get to transplant because their disease is too refractory. I think that the one question is, what do you do if someone gets salvage therapy and gets into complete remission? And I think that we don't have a good answer for. So it's possible that patients that are more chemosensitive may still do well with transplant, but the majority of these patients are not that chemosensitive. So the general thought is that if these patients who are primary refractory or early relapsing, it's a good idea to refer them to a CAR T cell center early to get assessed for CAR T and probably move in that direction. And also speaking to the fact that it seems that patients who get CAR T earlier may do better than those who get CAR T cells later. So I have another case. This is a different case. An 82-year-old male has a history of high-grade B-cell lymphoma. He has a MYC and BCL2 rearrangement, so double-hit lymphoma. He's initially treated with R-miniCHOP, so low-dose R-CHOP, and then 18 months later presents with clinic with relapse disease, so he's had a longer remission. He's initially was in a complete response post-chemotherapy, but then he presented with new axillary and inguinal lymphadenopathy, and a biopsy was concerning for relapse disease. He tolerated chemotherapy well. He lives with his wife and can generally do his daily activities on his own, although he's had more fatigue with his recent diagnosis, and daughter has been coming daily to check up on him and help him around the house. He usually walks at home and can walk around and get around, but to clinic, he needs to get a wheelchair due to the longer distances from the parking garage and navigating the area. So the question is, how do you treat this patient? Salvage therapy followed by an autologous stem cell transplant, an allogeneic stem cell transplant. Do you do CAR T cells for this patient in second line, chemotherapy, or hospice? And looks like most people are saying CAR T cell therapy. So going through, so this is based, so as we had mentioned, CAR T cells were approved in second line for patients who were early relapsing, so those within a year, and he's further out, but he's in his 80s, so may not be as good of a candidate for transplant. So there was a phase 2 study, so looking at second line therapy of CAR T cells, and the product was liso-cel for treatment of large B-cell lymphoma. And this was specifically a trial that was looking at patients who were not transplant candidates. So the reasons they included for enrollment were either older age, and they chose a cutoff of 70 or higher, a worse performance status, worse pulmonary, cardiac, renal, or liver function. And these patients did not have to be early relapsing or could have relapsed over 1 year post-initial therapy. So this was any second line. And most of even though they have these other organ cutoffs, I think most of the patients on this trial were enrolled either due to age. So they treated 61 patients. The median age was 74. About a quarter of patients had an ECOG performance status of 2. And the overall response rate was quite high at 80%, and with a complete response rate of 54%. And patients did seem to have more durable responses if they achieved a complete response. The median duration of response was 21.7 months. And a little over a third of patients had cytokine release syndrome, which is the inflammatory syndrome associated with CAR T cell therapy, although only one patient had grade 3 cytokine release syndrome, which is where we think about patients being in the ICU. And about a third of patients did have neurological toxicity, and 3 patients had more severe neurotoxicity, or what we call grade 3 ICANS, which are again associated with needing ICU level care. These results led to the FDA approval of liso-cel in second line for patients who are not transplant candidates, even if they relapse post 1 year of initial therapy. So in some more frail patients, I do consider CAR T cell therapy in those patients, even if they're not necessarily transplant candidates. So back to the initial case I was talking about with the patient who had large B-cell lymphoma, the younger patient with large B-cell lymphoma who relapsed, who relapsed within 6 months of completing chemotherapy. And how would you treat this patient? And looks like you all are paying attention, and I think this one I would treat with CAR T cell therapy, exactly. And then the next question is about this more frail patient, how would you treat this therapy? This is the more frail patient, and I don't know if this is left over from the last one, but similarly, like I would consider this patient for CAR T, most likely consider this more frail patient still for CAR T cell therapy. So here's an algorithm recently published to think about the care of patients with large B-cell lymphoma, with patients who relapse after first-line treatment within So those patients who relapsed within 1 year generally are thinking about CAR T-cell therapy immediately. If patients are relapsing more than 1 year post-treatment, I'm still considering them for salvage and maybe still referring them for transplant unless they're frail. And in those patients who are older or frail, I still think about CAR T in second line, even if they're late relapsers. And as you can see in the box in the middle for these other options for patients who are either not CAR T cell candidates or progress after CAR T, we have polatuzumab, which I mentioned earlier, but has also been approved in relapse refractory large B-cell lymphoma. They have selinexor here, which is a nuclear export inhibitor, which we really don't use that often, but is approved in this space. Other CD19-directed therapies, tafasitamab, and another drug, loncastuximab, and then and so there's a lot more options. This middle square is getting much more packed. There's a lot more therapies recently getting approved and being studied in large B-cell lymphoma. So, several years ago, or when I started practice, it was all pretty much just chemo, and now we have a lot more targeted therapies for these patients. And I'll be talking now about a new class of drugs that has received FDA approval in 2023 for large B-cell lymphoma, along with CAR T, and is also transforming care for our patients too. So what new drugs have been approved in lymphoma in 2022 and 2023? And we have mosunetuzumab for follicular lymphoma, mosunetuzumab for large B-cell lymphoma, epcoritamab for large B-cell lymphoma, glofitamab for large B-cell lymphoma, all of the above, or A, C, and D. And I don't necessarily expect people to know this, but I'll go through it in a little bit. We have a mix of answers, most people saying all of the above. So mosunetuzumab is a bispecific antibody, so I'll be which means that it targets CD3 and CD20. The goal of bringing the patient's basically bringing the patient's T cells to the CD20 expressing malignant B cells seen in lymphoma. So differently from CAR T, where we're extracting a patient's T cells and modifying them, this is a drug that basically a therapy that brings the patient's T cells to their B cells. So this was FDA approved in 2022 for relapse refractory follicular lymphoma after 2 or more lines of therapy. So this was the first bispecific approved in lymphoma. And this was based on the data from a clinical trial which treated 90 patients, and it showed an overall response rate of 80% and a complete response rate of 60% in patients with relapse refractory follicular lymphoma, with some durable responses, including an 18-month event-free survival of about 70% in patients who were complete responders. These are IV treatments. So initially there's weekly infusions where the dose is stepped up, and then subsequently patients get therapy every 21 days. And there are toxicities, some similar to CAR T, including cytokine release syndrome. And this is generally characterized by fevers, but in certain cases, patients can have hypotension and hypoxia. And the rates of cytokine release syndrome they saw were 44% in this trial. And this was mostly grade 1, which is generally just a fever alone, or grade 2, where patients may have hypotension or low oxygen requirements. And this generally occurs during either when the patient gets their first dose, the very first dose, or their third dose, which is their dose where they get the highest dose. And generally afterwards, patients don't, with future treatments, they definitely don't get any more cytokine release syndrome. So the advantage of this therapy is that it was fixed duration. So patients who got early response only had 8 cycles of treatment, and then they can stop. And so this was approved for follicular lymphoma. And then a few months later, earlier this year, epcoritamab was approved for large B-cell lymphoma. So this is also another bispecific, and this is same target, CD20, CD3. And the key difference from a practical standpoint is that it is subcutaneous administration. So hopefully decreased infusion chair time with that. The overall response rate for this patient population was 63%. So these are patients with relapsed refractory large B-cell lymphoma, some of the similar population we think about with CAR T cells as well, and a complete response rate of about 39%. So pretty similar response rate to CAR T cells. The median duration of response for patients who achieved a complete remission had not yet been reached. And cytokine release syndrome was seen in about half of patients, although again, mostly low grade. And the neurotoxicity rate was lower than what we generally see with CAR T cells, but was still there at around 6%. And one difference from CAR T cells is that this is a continuous therapy. So patients continue this therapy until they progress. And again, the toxicities generally happen with the first few doses. And then while I was working on this presentation, literally just a few weeks ago, glofitamab was approved. And this is another bispecific. And again, it was also approved for large B-cell lymphoma. So the same space as epcoritamab. And so that's who it's going to compete with. As opposed to epcoritamab, it is an IV infusion. And it also requires patients to get obinutuzumab, which is an anti-CD20 monoclonal antibody similar to rituximab. They have to get it 1 week before starting therapy with the thought that this will help decrease CRS rates. The response rates are similar, a complete response rate of 39%. And both on this trial and the epcoritamab trial, there were many patients who had prior CAR T before going on trial. And similar toxicity rates with this agent compared to epcoritamab. The main advantage here was that this is a fixed duration therapy. So the way they studied it was with 12 cycles total. So there is an endpoint here as opposed to epcoritamab, which is continuous therapy. But basically, mostly we're just excited about having these therapies, especially in the space of patients that are CAR T relapses. So in general, right now, my thought is that follow-up is still short. So we need longer follow-up for bispecifics compared to CAR T cell therapy. For CAR T cell therapy, we have a lot longer follow-up, suggesting that it can be curative in a proportion of patients. And we, of course, don't have this follow-up with bispecifics. And CAR T cell is a one-time treatment, while bispecifics are multiple treatments and injections. However, bispecifics seem to have an overall lower rate of cytokine release syndrome and neurotoxicity, so they may be a little bit easier to give. But we are still seeing infections, so we still with bispecifics, similar to what we see with CAR T cell therapy. CAR T cell therapy for now can only be given in specialized centers. And the question is whether community oncologists will be comfortable with giving bispecifics. I think eventually probably so. Right now, we're generally giving the first few doses at UNC where there's higher rates of toxicity, but it may be possible that once patients have gone on these therapies, they can be transitioned to their local oncologist too. But eventually, maybe larger practices may be able to manage this on their own as well. Another advantage is that you don't have to give lymphodepleting chemotherapy which is the kind of the conditioning therapy you give before CAR T cells with bispecifics. So you're avoiding that for them. So probably less cytopenias or low blood counts with bispecifics. And I think there's a lot of unanswered questions now around sequencing, which therapy you want to give first. My current approach right now is CAR T first if they're eligible, and then bispecifics afterwards if they relapse after CAR T. But there's going to be a lot more research in this space to figure out this timing as well. And then this was just the same question again. And that's right, ACND, but I can skip over it in the interest of time. So to summarize, biggest advances and changes in lymphoma over the past year or so. The one is incorporating of novel agents in Hodgkin lymphoma with brentuximab AVD, and I think very soon nivolumab AVD. The other change is incorporation of polatuzumab vedotin in frontline therapy of large B-cell lymphoma, and I expect that space to be changing as well. And then the third big news item is overall survival benefit with second-line CAR T in large B-cell lymphoma. And early referral to CAR T-cell treatment is really important. And more patients will be getting CAR T-cell, more patients are CAR T-cell candidates that you may expect. And we have treated many patients in their 80s here as well. And finally, bispecifics have entered a treatment arena, and we'll be using them more and more in lymphoma as well. And I think that is see it. Thank you, and I'm happy to answer questions.
All right, Dr. Grover, thank you so much. That's a phenomenal amount of information that you shared with us today. We really appreciate that. Let's see, let me check and see if any questions have come in. I did have one. If we don't have any that have been delivered yet. Yeah, we're still waiting on questions. So please use Poll Everywhere. Go ahead and share those questions with Dr. Grover, and we'll get to as many of those as we can. I was fascinated. Early on, you talked about selecting the primary therapy versus salvage therapies. And I was interested in if you could talk for a minute about the decision-making process, because I know you mentioned, toxicity, neuropathy, side effects there, but how would that potentially differ depending on the patient in terms of essentially using the big guns up front that may have more toxicity versus selecting those as salvage therapies?
Yeah, no, definitely. I think it's definitely conversations with the patient. I think in general, and different people have different views about this, but in terms of thinking about Hodgkin lymphoma with brentuximab, incorporating brentuximab in frontline, even though it has some more toxicity, the general thought is that if they relapse, right now the standard of care for Hodgkin if they relapse is a stem cell transplant, which is of course pretty intensive and toxic therapy. So even adding a little bit of extra toxicity, potentially adding some extra toxicity frontline, may be worthwhile if you're reducing their risk of transplant. But some of it also depends on a patient's pre-existing issues. If a patient has a lot of underlying neuropathy or other issues, then I may avoid using a drug that causes a lot of neuropathy. Or when thinking about checkpoint inhibitors, if they have if they have autoimmune diseases or other risk factors for some of the immune toxicities, we may not want to give those therapies as well.
Great. Thank you so much. I appreciate that. And a question just came in. Is there a chance of CAR T therapy moving to frontline treatment for a broader spectrum of lymphoma types?
That's a really good question. I think for large B-cell lymphoma, there are some trials incorporating. Right now, it's mostly, there's obviously a cost component as well. And we know we're curing a lot of people with some of these therapies, but we have these high-risk patients of double hit lymphoma who are really high risk. And some of these patients were moving CAR T cell therapy. There's some trial, I think it's the Zuma 12 that they have long, but where patients get 2 cycles of chemo and then they get a PET scan, and the PET scan shows a poor response, they go ahead and give them CAR T cells at that point. So kind of incorporate it into frontline therapy. So in these highest risk patients, there are frontline trials, and I think they're planning on doing a randomized trial as well for these high risk patients where they incorporate CAR T.
Great. Thank you so much. And we are coming up on the hour, so we'll take this final question. Yeah. Is there an optimal timing to start bispecific antibody treatment if a patient fails CAR T therapy?
That's a really good question. I think we don't really know. In general, as long as a patient has recovered from their toxicities from a CAR T cell standpoint, I'm comfortable giving patients bispecifics after they progress on CAR T cell therapy. Sometimes there's issues of cytopenias and other things that may sometimes make it challenging to start other therapies. But in general, I am comfortable having bispecifics as the next line of therapy after CAR T, and there have been trials looking at that. And there's actually a trial looking at a cooperative group trial looking at partial responders, so not patients at 1 month post CAR T, if they're in a stable disease or partial response, giving them bispecifics at that point to see if that can improve their response. So there's interest in looking at that too.
Thank you so much, Dr. Grover.
Thank you very much.
Let's see. Let's take a look. We just looking at a couple of final remarks. I do want to thank everyone for attending today. We had great attendance and really appreciate your being here. Want to thank the people of North Carolina for their generous support of the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We want to thank Benny Obure, John Powell, Oliver Marth, Andrew Dodson, Nadja Brown, Patrick Muscarella, and our summer intern Laura Lowe for all of their work to make all of these possible.